Today we are going to show you how to reduce wrinkles within 90 days. If your wrinkles have been getting deeper over the past few years, and you have tried the moisturizers, the collagen creams, maybe a serum or two, and the difference has been minimal, I want to offer you a different explanation. Not a new product, not a new routine, a different understanding of what is actually happening beneath your skin. Today, Suki and I are going to show you exactly how to slow and visibly reduce deepening wrinkles after 60, using 3 targeted interventions that work at the structural level, not the surface. And the research shows that applied consistently, you can see a meaningful difference in wrinkle depth within 90 days.
Hi, I'm Suki Yamamoto, wellness specialist.
And I'm Marcus Reid, your senior health coach. What we're covering today is why wrinkles do not just appear after 60, they deepen. There is a specific biological reason for that. 3 reasons, actually. And none of them are the reason most skincare marketing would have you believe.
I want to be precise about what we mean by deepening specifically. Fine lines, the kind that appear in your 40s, are primarily surface-level changes, the skin's outer layer becoming less hydrated, less elastic. What happens after 60 is structurally different. Wrinkles become deeper, more defined, and significantly less responsive to topical products. That change is driven by 3 things happening simultaneously beneath the skin. We are going to take each one apart and then walk through the interventions that the evidence actually supports.
No fads, no miracle claims, just what the research actually shows and what it looks like in practice. Let's jump into the studio. Here is what most people do. They notice the wrinkles getting worse. They buy something that says boosts collagen on the jar. They use it for 6 weeks. They do not see much of a difference, and they either conclude it does not work, or they go looking for a more expensive version of the same thing.
The problem is not always the product. Some products contain genuinely useful ingredients. The problem is that those ingredients are being applied to the surface of the skin, while the structural changes driving deeper wrinkles are happening well below that surface, in the dermis, in the subcutaneous tissue underneath it, and at the hormonal level. A cream on the epidermis cannot reach all 3 of those layers effectively.
So wrinkle creams are not useless. They are addressing the symptom, not the structure.
That is a fair summary. What we are going to do today is explain the 3 structural mechanisms so that whatever you choose to do is based on an accurate picture of what is actually happening, and then walk through the specific interventions that the evidence supports at each level.
And I think what most people watching this will find useful is that some of this is topical. Yes, products, but some of it is dietary, and some of it is about understanding what has changed hormonally and what that means for your approach. It is not one single thing.
Correct. And someone who is only addressing one of the 3 is likely to see limited results, not because the intervention is wrong, but because it is incomplete. The first mechanism is collagen cross-linking. I want to explain what that means precisely because it is often mentioned in skincare content without any real explanation of the biology.
I have seen it on product labels. Fights collagen cross-linking, but I genuinely had no idea what it meant.
Collagen is a structural protein. It provides the scaffolding that keeps skin firm, thick, and resilient. In younger skin, collagen fibers are arranged in relatively loose, parallel bundles that move and stretch easily. As we age, a process called glycation causes sugar molecules to bond with collagen fibers, forming compounds called advanced glycation end products, AGS. These bonds cause collagen fibers to stiffen and tangle, cross-linking, meaning they stick to one another in a rigid, disorganized way.
So the scaffolding underneath the skin literally becomes brittle.
That is exactly the right word. A 2000 study published in the biochemical journal by Verzile and colleagues modeled the accumulation of AGEs in human collagen over a lifetime and found that by the age of 80, the majority of collagen in the skin showed significant glycation-related cross-linking, and crucially, the rate of new collagen turnover slows dramatically after the age of 60, meaning the damaged cross-linked collagen is not being replaced as efficiently as it once was.
So you have rigid scaffolding, And the process that would normally replace it with fresh scaffolding is slowing down at the same time.
Both happening simultaneously, and the result at the surface is deeper, more defined wrinkles that do not respond to hydration the way they once did, because the structural problem is below the surface, not at it.
Is glycation something you can control? Is this driven by diet?
Partially. Dietary sugar and refined carbohydrates accelerate glycation, that is established. A dietary pattern high in refined carbohydrates will, over years, accelerate the rate of AGE accumulation in collagen. I want to be more careful than most sources are here. This does not mean sugar causes wrinkles in a simple one-to-one way. It means that the cumulative effect of high circulating glucose on collagen integrity is meaningful over a decade. That distinction matters.
So reducing refined carbohydrates is one lever. What else can be done?
We will come to the interventions. But the second mechanism needs to be understood first because it explains a completely different dimension of why wrinkles deepen, and it is the one that almost nobody has heard of.
Okay, what is the second mechanism?
Facial fat compartment loss. This one is less well known outside of plastic surgery and clinical dermatology, but it is significant. The face is not simply a layer of skin over bone. Between the skin and the bone, there are distinct, anatomically separate fat compartments, discrete pockets of fat distributed across the forehead, the cheeks, around the eyes, and along the jaw. These compartments provide structural support beneath the skin. They maintain the shape and contour of the face.
Like a cushion beneath the surface.
Precisely. A 2007 study by Rorik and Pessa, published in Plastic and Reconstructive Surgery, mapped these compartments in detail and demonstrated that they are anatomically discrete, meaning they lose volume independently of one another. After 60, these fat compartments atrophy. They do not shrink uniformly. They deflate at different rates in different areas, causing the skin above them to fold, sag, and crease.
So when someone sees the skin around the mouth getting more lined or the cheeks beginning to fall, that is not just the skin losing elasticity, it is the structure beneath it changing.
The analogy I would use is a fitted pillowcase. If the pillow inside is full, the pillowcase stays taut. If the pillow begins to deflate unevenly, the pillowcase develops folds and wrinkles regardless of its own condition.
That is actually a genuinely useful image, because it explains why someone can have relatively healthy skin texture and still have deep lines around the mouth or under the eyes. It is not the skin itself that is failing. It is what is underneath it.
Exactly. And this is why certain topical products, even genuinely effective ones, can only do so much. They are addressing the pillowcase when part of the problem is the pillow.
Can you do anything about this? Can the fat compartments be restored?
This is where I want to be honest about the limits of what lifestyle and topical interventions can achieve. The loss of facial fat compartments with age is largely structural and is not fully reversible through diet or topical application. Medical interventions, specifically hyaluronic acid fillers, are designed to address this directly by restoring volume beneath the skin. That is outside the scope of what we cover here, and it is a conversation for a qualified aesthetic physician.
So why are we discussing it if we cannot address it ourselves?
Because understanding it changes how you evaluate what topical products can and cannot do. If someone has tried everything and still sees deep nasolabial folds or pronounced hollowing under the eyes, the structural explanation is more likely than a product failure. That is genuinely useful information. It means the appropriate next step is a medical conversation, not another serum.
You are not failing. The approach may simply have reached its ceiling.
And the third mechanism, estrogen withdrawal, is where the interventions we will describe can make a meaningful, measurable difference. That is where we have the strongest evidence for practical action.
Estrogen. Walk me through the connection to wrinkles specifically.
After menopause, estrogen levels decline sharply and do not recover. That is well understood. What is less commonly discussed is the specific effect of estrogen withdrawal on the skin's structural maintenance system. Fibroblasts are the cells in the dermis responsible for producing new collagen and elastin, the two proteins that provide structure and elasticity to the skin. Fibroblasts are highly sensitive to estrogen. Estrogen receptors have been identified on dermal fibroblasts, and estrogen directly stimulates their activity.
So when estrogen drops, the cells that build new collagen slow down.
Significantly, a widely cited review by Shah and Maibach, published in the American Journal of Clinical Dermatology in 2001, summarized multiple studies showing that women lose approximately 30% of skin collagen in the first 5 years after menopause, and a further 2% per year after that. This is not gradual general aging. This is a specific, hormonally driven collapse in the rate of collagen production.
30% in 5 years. That is a rapid change.
It is, and it explains why many women notice that their wrinkles deepen significantly in their early 60s, which corresponds to roughly 5 to 10 years post-menopause. The cumulative effect of reduced collagen production over that period becomes visually apparent.
What about HRT? Can replacing the estrogen address this?
Hormone replacement therapy is a medical intervention with a complex risk-benefit profile that varies significantly between individuals. There is evidence that HRT can slow the rate of skin collagen loss in postmenopausal women. Brinkat and colleagues published studies in the 1980s demonstrating measurable increases in skin collagen thickness in women using estrogen therapy. But the decision to use HRT involves considerations well beyond skin health: cardiovascular risk, individual medical history, cancer risk factors. That is a detailed conversation for your physician. We are not in a position to recommend it based on skin benefits alone.
So for someone who is not on HRT and is not considering it, what is the practical response to fibroblast slowdown?
This is where topical interventions have their strongest evidence base. There are 3 ingredients with robust clinical support for stimulating fibroblast activity and collagen synthesis in postmenopausal skin. We have actually covered 2 of them on this channel before, but today, for the first time, we are going to explain exactly how to layer all 3 together.
Let's go through them one by one.
The first is retinoids. Retinol and its prescription-strength derivative tretinoin are the most extensively studied topical ingredients for wrinkle reduction. The mechanism is directly relevant here. Retinoids bind to nuclear receptors in skin cells and upregulate gene expression for collagen synthesis. They instruct your fibroblasts to produce more collagen. A study by Griffiths and colleagues published in the New England Journal of Medicine in 1993 demonstrated that topical tretinoin applied for 22 weeks produced significant improvement in fine lines and wrinkles, with biopsy evidence showing measurable increases in new collagen production.
22 weeks. That is longer than 90 days.
It is. I want to be precise about the time frame. Most retinoid studies run between 12 and 24 weeks. At 12 weeks, approximately 90 days, studies consistently show visible improvement in fine lines and mild wrinkle reduction. Deeper structural improvement continues beyond that point. The honest answer is 90 days of consistent retinoid use is likely to produce visible change. Full benefit accumulates over 6 months to a year.
That is important context, because people give up at week 6 when they are not seeing results yet.
Biologically premature. The skin cell turnover cycle is approximately 28 days in younger skin and slows to 45 to 60 days in skin over 60. Collagen remodeling takes additional time beyond that. Patience is, again, the part nobody wants to hear, but it is what the biology requires.
What strength of retinoid? Over-the-counter versus prescription?
Over-the-counter retinol is converted by the skin into retinoic acid, the active form, but this conversion is inefficient. You need a higher concentration to achieve the same effect as a lower concentration prescription product. For someone who has never used a retinoid, starting at 0.3 to 0.5% is appropriate. Lower concentrations significantly reduce the initial irritation, redness, and peeling that many first-time users experience. If you tolerate it well after 4 to 6 weeks, you can increase to 1%. Prescription tretinoin, if your GP or dermatologist is willing to prescribe it, will produce faster and more significant results, but the initial adjustment period is more pronounced.
What is the second ingredient?
GHK-Cu, the copper peptide. We covered the mechanism of GHK-Cu in depth in a previous episode, so I will keep this brief here. GHK-Cu stimulates fibroblast activity directly. It upregulates gene expression for collagen, elastin, and glycosaminoglycans, the compounds that maintain moisture in the dermis. A 2018 review by Picard and Margolina in the International Journal of Molecular Sciences summarized evidence showing that GHK-Cu influences over 4,000 human genes, many of them involved in tissue repair and collagen synthesis. In the context of the fibroblast slowdown we have just described, GHK-Cu applied topically is working with the biology, not against it.
Can you use retinoids and GHK-Cu together?
This is a practical question worth addressing directly. Both can be used in the same routine, but not at the same time. Retinoids are typically used at night. GHK-Cu serum is better placed in the morning routine or on alternating nights if you prefer it as part of an evening routine. The reason for separation is that retinoids increase skin permeability, which can amplify irritation when combined with other active ingredients at the same moment.
Simple. Retinoids at night, GHK-Cu in the morning.
That is a sound default. The third ingredient is vitamin C, ascorbic acid. The mechanism here is also directly relevant. Vitamin C is an essential cofactor in collagen synthesis. Fibroblasts cannot produce stable, structurally sound collagen without it. A study by Nuskins and colleagues published in the Journal of Investigative Dermatology in 2001 demonstrated that topical vitamin C significantly increased the mRNA levels for collagen type 1 and type 3 in human skin, meaning it upregulated the cellular instructions for collagen production at the molecular level.
So vitamin C is not just an antioxidant in this context. It is a direct input into the collagen-making process.
Correct. And the form matters. L-ascorbic acid is the most studied form, but is also the most unstable. It oxidizes quickly on exposure to air and light. If your vitamin C serum has turned orange or brown, the active ingredient has already degraded and the product is no longer effective. Look for serums with 10 to 20% L-ascorbic acid in opaque, airless packaging. More stable derivatives, such as ascorbyl glucoside or sodium ascorbyl phosphate, are also worth considering. They penetrate more reliably and are better tolerated by sensitive skin.
And the dietary piece? You mentioned earlier that high sugar intake accelerates cross-linking. What else does diet do in this picture?
Dietary protein is the fourth lever, and the most consistently overlooked. Collagen synthesis requires specific amino acids, glycine, proline, and hydroxyproline. These come from dietary protein. A study by Shaw and colleagues published in the American Journal of Clinical Nutrition in 2017 demonstrated that vitamin C-enriched gelatin, a collagen precursor, taken consistently increased collagen synthesis markers in connective tissue. The broader evidence shows that dietary protein intake is a rate-limiting factor in collagen production in older adults.
So if you are not eating enough protein, your fibroblasts, even if stimulated by a topical, do not have the raw materials to produce new collagen.
That is a fair summary. Current guidance for adults over 60 points toward 1.2 to 1.6 grams of protein per kilogram of body weight per day, higher than standard recommendations for younger adults because protein absorption efficiency declines with age. We covered this in the context of muscle mass in a previous episode. The same principle applies here.
So the full protocol is retinoids at night to stimulate fibroblasts, GHK-Cu in the morning to support collagen and elastin synthesis, vitamin C serum in the morning to supply the cofactor, and adequate dietary protein to give the whole system its raw materials.
That is the protocol the evidence supports. 4 inputs targeting the same biological problem from different angles.
I want to ask about expectations. Someone who is 65 and has deep wrinkles, what is a realistic outcome here?
Let me be specific. The most realistic outcomes are a slowing in the rate at which wrinkles deepen further, visible improvement in fine lines and skin texture, and some degree of wrinkle reduction in areas where the primary driver is fibroblast slowdown and collagen cross-linking, not fat compartment loss. That is the important nuance. For wrinkles driven primarily by volume loss beneath the skin, deep nasolabial folds, pronounced hollowing under the eyes, topical interventions will have limited impact. For wrinkles driven by surface loss of collagen and elastin, fine lines across the forehead, texture changes on the cheeks, the interventions we have described have good evidence behind them.
So how does someone know which they are dealing with?
A rough guide. Press gently on the wrinkle with one finger and lightly stretch the surrounding skin. If the wrinkle largely disappears with that light pressure, it is more likely surface-driven and more responsive to topical intervention. If it remains prominent even with the skin stretched, it is more likely structural, driven by volume loss, and may warrant a medical conversation.
That is a practical test someone can do at home.
It is a rough guide, not a clinical diagnosis, but it helps set realistic expectations, and about the 90-day time frame, I want to be precise. At 90 days of consistent application, the evidence supports visible improvement in fine lines and mild wrinkle depth, particularly from retinoids. Deeper structural improvement continues beyond that point. If you apply this protocol for 90 days and see no change at all, that is worth discussing with a dermatologist. It may indicate that fat compartment loss is the primary driver rather than collagen deficit.
We are not making a reversal claim. We are saying, understand the 3 mechanisms, use the 4 interventions with the best evidence behind them, give it a minimum of 90 days, and evaluate honestly.
And accept that some of what you are seeing after 60 reflects structural changes that current evidence does not support, fully reversing through topical or dietary intervention alone. That is not failure. That is an accurate understanding of the biology.
Let's bring it home. Today we explained why wrinkles deepen after 60, and why it is not simply about dry skin or surface aging. The 3 structural mechanisms are collagen cross-linking and AGE accumulation, stiffening the scaffolding beneath your skin, facial fat compartment loss, removing the structural support that keeps skin taut, and estrogen withdrawal, slowing the fibroblast cells that produce new collagen and elastin.
The evidence-supported interventions are retinoids, topical retinol over-the-counter or tretinoin on prescription, to stimulate fibroblast collagen production, GHK-Cu peptide serum to further support collagen and elastin synthesis, topical vitamin C to supply the essential cofactor for collagen formation, and adequate dietary protein, 1.2 to 1.6 grams per kilogram of body weight, to give the fibroblasts the amino acid building blocks they need to do their work.
Retinoids at night, GHK-Cu in the morning, vitamin C serum in the morning, protein at every meal, and 90 days minimum before you evaluate, because the biology does not operate on a 2-week timeline.
If some wrinkles remain deep and unresponsive despite consistent application, The structural conversation about volume loss and what a physician can offer is a reasonable and appropriate next step. That distinction matters.
If this was useful, the like button genuinely helps more people find it. Subscribe and turn on notifications so you don't miss next week.